Good morning and good afternoon, good evening from wherever you're calling from in the world. We thank you for joining us today in our Global Ground Rounds 2026 first quarter. My name is Dr. Herbert Oye, and it's our pleasure to have you here today. For the USA participants, we thank you for braving through the snow to be here today, and we look forward to having an exciting program. As usual, the Global Ground Rounds is a program that's dedicated to emanate our educational excellence, both for clinicians and non-clinicians. And the program is designed also to help increase our awareness about vascular diseases in general, and particularly in this particular session, we'll key on the prospects of peripheral artery disease. I'd like to take this opportunity also to thank our participating collaborators, the Uzuma Foundation, whose vision is to help improve healthcare access in Africa, and the Oye Global Medical Foundation, which has continued to help improve endovascular vascular care in medical underserved communities in Africa, as well as education and scholarship for young men and women who deserve it. In addition to that, would also like to thank other participant partners, the Dialysis Specialist Hospital, that continues to provide care for indigents in dialysis state and beyond, as well as the Endovascular Clinic, Lagos. Particularly also, we would love to extend thanks to the Silver Cross Hospital in Abuja, as well as Silver Crest Hospital in Lagos. On behalf of all our partners, again, welcome to our program. Today we have an exciting array of topics with a theme based on PAD, peripheral artery disease, which, as I will mention towards my closing remarks, is global hazard. We would have young physicians training talk about PAD, and they'll present some case studies that will highlight the importance of PAD and how management can make a difference, early management that is. So once more, welcome to our Global Ground Rounds. We're starting 1 hour earlier this month, and this year to help get activities on the way. So welcome, and our first presenter, again, as housekeeping rules before our first presenter comes on, we have student Dr. Ibrahim Bikule, who would be managing the structure of the program. And he's been our coordinator for the program for many years now. And we have other presenters who would be coming on the podium shortly. And our first presenter is student Dr. Michael Aycock, and he has completed his vascular surgical rotation under my tutelage. And he's now a full-fledged, comprehensively trained endovascular medical student. So welcome, Dr. Aycock.
Thank you, Dr. Oye. Ibrahim, could you show me how to pull up the PowerPoint, please? In there. Slideshow. Good morning. We're going to be addressing a complicated lower extremity revascularization using multiple techniques with a positive outcome. The techniques used in proximal and distal approaches, in this case, we went in first below the knee and then in the groin. So the traditional techniques will be the endarterectomy, the angioplasty, stenting, and the shockwave device. That was FDA approved in 2016. If you'd like to read a meta study confirming its comparative benefit, I've got it referenced here, the Disrupt PAD 3 study in 2020. Now, the endarterectomy is a simple process, often difficult to do, but opening the artery and removing the plaque. The angioplasty is passing a wire into the vessel, and with a balloon, you're opening the vessel if there's compliance within the plaque in the vessel. Then stenting is reinforcing the arterial diameter if the plaque was tending to move back into the vessel with an artificial expanding mesh. And the newer device is the shockwave. Now, the shockwave, it goes on a device, and it's a catheter on the device, and it's going to use a sound wave. It's similar to lithotripsy. It's going to use a sound wave to break up the calcium within the plaques, and that's going to make the vessels compliant again so that you can keep the vessel open. And then you can do further angioplasty or stenting within the catheter that you've brought in for the shock wave. The device looks like this. The black and yellow portion at the end, of course, you don't use twice. And the device is starting with the blue. And there's a button on the device right here. And when you hold it down, you're going to hear the clicks. And each click is a wave. And the wave is shaped like this. The wave will create up to 50 atmospheric pressures, and that's what creates those microfractures within the calcium, and that's how the plaque is broken up and made soft again. Now, our patient, 94 years old, female, high cognitive function. She's generally happy, ambulatory. She's got a history of AFib. Now, this becomes important when you hear it in just a moment. She's regularly on warfarin, prior strokes, prior seizure disorder. The patient ceased blood thinners for a dental procedure. 5 days later, the patient was taken to a clinic for leg pain. The clinic diagnosed her with arthritis. Now, we weren't at the clinic, and I don't know what her symptoms were at the moment. This is not an uncommon diagnosis for extremity pain in a patient at this age. A few days later, the pain had increased, causing an ER visit, and we're glad that her family was wise enough to bring her because time became an issue. She presented with no distal pulses and a cold extremity. Treatment began after midnight in the vascular suite. The CT angiogram revealed complete occlusion of the femoral and non-patent profunda that diminished or absent pulses distally. With the patient being so active, being no dementia, moving around, conversive, and happy, the family, the patient, and the physician decided that it was worth the risk of the anesthesia and the procedure. In a less active person of this age that might not have mentally been there or had other disabilities, maybe they were bedridden, that might have led to a different decision, which could have led to decline, loss of life, or possible amputation, but the surgery has risk of its own. In considering how far to go, if you can clear through the profunda, you can maintain the life of the foot and the lower leg, but they may not get full blood supply and they may not be as ambulatory. The goal would be to clear the femoral. And when you clear the femoral, then you've got a much better chance of full function. Now, the first incision was an attempt to move up the leg. And so he made an incision below the knee, and existing clots and plaques would not allow him to work up the popliteal and to the femoral. And so those were failed attempts, but there was good news. With the contrast fluoroscopy, it was clear that there were patent vessels down all the way through the foot. So if we could get the blood down to below the knee, then there was a good chance, and that balloon, stent, or bypass, the bypass being more traumatic, of course. Working down from the top, we had partial success. There was a groin incision, and endarterectomy was performed, large plaque removed. Working proximal to distal, they cleared the common femoral, the superficial femoral, and the branch of the profunda. Some distal flow was reestablished, and we had the fluoroscopy showed partial flow. And then we brought in the shockwave device for much greater success. And you can see the measurements there, but the shockwave, we used a 3x60 balloon, a 4x40 balloon, a 4x40 stent, and a 6x130 stent. And then we had strong distal pulses, and the fluoroscopy indicated very strong blood flow from that point. Post-surgery, and this was great, patient was resting comfortably with family in the hospital room. The appetite was good. She was able to stand and participate in therapy. Vitals were stable. Incisions were healing appropriately. On this slide, you can see from the endarterectomies what was removed at the femoral approach and the popliteal approach, and there are your incisions. If you look at the incision from the lower leg approach, you can see the catheter and wire attempting to go up. On this slide, you can see the blood supply to the fluoroscopy showing possibility of blood supply to the foot later. On the right, you can see some dissection and blockage within the popliteal going up that made it difficult to work from the distal location. In this slide, you can see the wire placement from the groin and some of the angioplasty and shockwave in the upper leg. And then we wound up with a well-perfused lower leg because of what we were able to accomplish from the top down and with the shockwave. The outcome is expected to be a senior female with continued mobility and an active lifestyle. If partial blood supply had been brought down just from the profunda, she could have had some mobility. She might have lost the ability to walk, but the leg would have lived. By clearing the femoral artery and the popliteal, she should be able to maintain quality of life. Without the corrective procedures, she could have faced amputation, sepsis, loss of mobility, loss of independence, possibly moving into skilled nursing care, and possibly death. It should be noted that the shockwave device is, and I'm not going to be publishing numbers and stuff, but the shockwave device is quite expensive and the application of it is expensive, but it did have a good outcome in this case. Thank you.
Thank you, Mike. Our next speaker will be Ruwangi Semage.
Hi, everyone. I will be discussing the case of multi-level peripheral arterial disease with iliac aneurysm, which was treated by combined open and endovascular revascularization. So to begin with, I'm going to be talking a little bit about peripheral artery disease, which is a progressive atherosclerotic condition that may lead to critical limb ischemia, tissue loss, and amputation if it's left untreated. The narrowed arteries reduce blood flow to the limbs, typically the legs. And this is a multi-level disease which involves the iliac and femoral popliteal segments, and it presents a therapeutic challenge, which often necessitates a hybrid surgical approach. Now, peripheral artery disease is primarily caused by atherosclerosis and is accelerated by diabetes, uncontrolled hypertension, and smoking. Some of the top symptoms that you'll see is pain with activity, so claudication or at rest, pulselessness, which is lost or diminished pulses, paresthesias, which is abnormal sensation and tingling, paralysis, pallor, which is due to the diminished blood supply to the region, and a cold leg, which we call poikilothermia. Now, the statistics in USA is that it's present in more than 12 million Americans and worldwide in 200 million individuals. So the prevalence depends kind of on definition because the inclusion of symptomatic patients only tends to underestimate the disease burden. And of course, the rates rapidly rise with age. So our highest prevalence of PAD is in adults over 70 years. Now, severe peripheral artery disease with critical limb ischemia may lead to amputation. This affects about 1.3% of adults here in the US. There are many types of interventions we can use. So we have balloon angioplasty, which you can see here. There's also stenting and atherectomy, where you remove the plaques. Our patient was an 80-year-old male. He had known peripheral arterial disease. He was presented for operative management because of severe left lower extremity arterial insufficiency. You can see that in this image that he has a blockage, and there's also a dilatation in his artery. His medical records documented that he had advanced atherosclerotic disease. He also had a history of cystitis and hematuria, which was reported by his family. So our pre-op showed that he had peripheral arterial disease. There's also left iliac artery stenosis and complete occlusion of the left femoral popliteal segment. And there was also aneurysmal dilatation of the common iliac artery, which was measuring 3.6 centimeters. The procedure that we did was open surgical exposure of the common femoral artery, superficial femoral artery, the profunda femoris artery, and the popliteal artery. And then endarterectomy was performed to remove plaque from these arteries. Then we went on to do angioplasty and stenting, which was also in the common iliac artery, which was a covered stent, the external iliac artery, and then, of course, the entire femoral popliteal segment. So you can see a stent here. The procedure then included shockwave intravascular lithotripsy, which my colleague Michael went over earlier, and that was used to break the severe arterial calcium. The HemoShield patch was used to repair arterial openings. You can see an image of that here. The overall estimated blood loss was 1,500 milliliters. We ran into a significant bleeding during the operation due to the heavy calcification that was controlled surgically. Post-op, we looked at the dorsalis pedis and posterior tibial pulses. Those were detected by a Doppler examination. The patient tolerated the procedure really well. They had no immediate surgical complications. There was a bit of mild hematuria noted via the Foley catheter. That was consistent with the patient's prior history, and the platelet count was 114,000. Plans were made to continue monitoring this patient's hemoglobin and hematocrit levels, and also urologic consultation for the persistent hematuria. So the diagnostic assessment at the end of the day was this patient had severe calcification, also had stenosis, complete occlusion of the femoral popliteal arteries. There was aneurysmal disease of the left common iliac artery. And medical therapy alone was deemed insufficient due to the extent of this patient's disease. So this case illustrates essentially the complexity of managing advanced multi-level peripheral artery disease in an elderly patient. And we used hybrid open and endovascular techniques, which allowed for comprehensive revascularization. We treated the aneurysmal disease, and there was restoration of the distal perfusion. Then intravascular lithotripsy was used, which really helped with the heavily calcified vessels. And successful limb salvage was achieved, which really emphasizes the importance of individualized surgical planning in PAD. Most importantly, this procedure allowed us to avoid bypass. So here's a before and after. As you can see in the first image, they had the aneurysmal dilatation as well as occlusion. And in the second image, you can see that the distal perfusion has been restored. So multi-level peripheral artery disease with complete femoral popliteal occlusion and the iliac aneurysm was effectively managed using combined open and endovascular techniques. And so this approach resulted in restored blood flow and limb salvage, which didn't have any immediate complications. Now, our long-term outcomes kind of depend on making sure that there's post-operative surveillance and management of the underlying atherosclerotic disease. And just a few acknowledgments going out to Dr. Oye, as well as the surgical team at Raleigh General Hospital and the anesthesia team at Raleigh General Hospital. Thank you.
Thank you, Dr. Nice job. Hold on, Ru. Our next speaker is Ngebui Chafeh, who will be discussing two very interesting peripheral artery diseases cases. Ngebui, please, the floor is yours.
Okay, hello everyone. My name is Ngebui Chafeh. I'm going to do the case. I'm going to be talking about two clinical cases. First, I'm going to do a brief introduction on just like what peripheral arterial disease is and how we can go about handling this disease. And I'd like to say a special thank you to Dr. Oye for allowing me to shadow him during my clinical rotation. And thank you for all of the sponsors and attendees today. So a brief introduction, peripheral artery disease is a common vascular condition where plaque buildup, atherosclerosis narrows the arteries, most often in the legs, reducing blood flow and oxygen to the limbs. So for epidemiology, it's a major global cardiovascular issue affecting over 200 million people, with prevalence rising sharply with age and higher rates in low middle income countries. It is primarily caused by atherosclerosis, disproportionately affecting Black individuals over white adults with significant risk of amputation and cardiovascular mortality. So here is a global study based on utilized national level data from the 2021 Global Burden Disease dataset to project peripheral artery disease prevalence by 2025 across countries and world regions. By integrating projections of key metabolic risk factors and modeling their impact on peripheral artery disease prevalence from 1990 to 2001. Their analysis provided a nuanced understanding of the future burden of peripheral artery disease. Additionally, it employed analysis to quantify the relative contributions of population growth, aging, and changes in risk factors to the projected trends. This information is critical for public health planning, particularly in ensuring adequate resource allocating to meet the growth demands of peripheral artery disease patients and their caregivers. As population growth and aging emerge as major contributors to the increasing burden, urgent research is needed to develop disease-modifying therapies, cost-effective prevention strategies, and interventions targeting modifiable risk factors, which will be discussed later on in this presentation. So this study is globally reviewed. It represents data sources from peripheral artery disease prevalence, mortality, and disability-adjusted life year, which I wanted to talk a little bit about considering my background in public health. So disability-adjusted life year, it measures the overall disease burden, combining years lost to premature death and years lost to disability for a specific condition, effectively representing a year of healthy life lost. So as you can see on the picture to the right, the one on the bottom really shows the projected growth rate, and it's highly concentrated in regions of Africa. So, for example, a sudden death at age 15 represents 65 DALYs, assuming a life expectancy of 80 years, as 65 years of life was lost prematurely. So in essence, DALYs quantify the gap between a population's current health and a desired state of full health, making it a powerful tool for global health planning, which is why resources and planning and just availability just really plays an extreme role in this case. So signs and symptoms. If left untreated, severe peripheral artery disease can lead to limb-threatening complications like critical limb ischemia, a severe obstruction of blood flow causing pain, coldness and numbness at rest, and/or tissue death. Both cases leading to amputation. So as we see in the picture, key symptoms, leg pain, numbness, cramping when walking, slow healing sores, and poor nail growth. So for risk factors, as we already discussed, most often caused by atherosclerosis, fatty buildup deposits. Other major risk factors are smoking, diabetes, which is why it's so pronounced in the United States, high blood pressure, high cholesterol, obesity, and older age. So complications, again, we mentioned critical limb ischemia, amputation, infection, caused by poor circulation, which makes it hard for the body to fight infection from those limbs, heart attack and stroke from the plaque buildup, and of course, reduced mobility from the claudication, limiting the walking and performing the activities of daily life. Treatment options, we have lifestyle changes, which is The one that we really want to go for, quitting smoking, exercising regularly, following a healthy diet. These are things that a patient can control, and it's very much targeted for preventative care. Medications such as blood pressure medication, cholesterol, blood sugar, and those that improve blood flow to prevent clots. And then, of course, we have the procedures such as angioplasty, stenting to widen arteries, or bypass surgery to restore the blood flow. So our first case, subclavian arterial occlusion in an elderly female. So this patient is a 68-year-old Caucasian female with a history of right subclavian artery occlusion, status post-embolectomy, who presents with recurrent pain in the right upper extremity. Her symptoms raise concern for recurrent arterial insufficiency. CTA was performed and vascular surgery was consulted. Imaging demonstrated continued restenosis of the right subclavian artery, and given persistent symptoms, the decision was made to proceed with a right carotid subclavian bypass. So her past medical history, again, she had recurrent right subclavian arterial occlusion, hypertension, hyperlipidemia. Those are the three main contributing factors for her condition, in addition to the peripheral neuropathy, reflux, anxiety, depression, hypoxemia, and hypokalemia. This patient did use vapes. Right subclavian artery stenosis, status post-repair in her past surgical history, and a bilateral tubal ligation. She did have a family history of coronary artery disease in her mother. She stated that she does not smoke, drink, or use other drugs, allergies to penicillin, and review of systems, all pertinent to her HPI. So here's a summary of the physical exam. So her vital signs were stable. Exam of the right upper extremity revealed decreased warmth and delayed capillary refill compared with the left. Radial and ulnar pulses were diminished on the right and palpable on the left. Blood pressure was lower in the right arm compared with the left. Sensation was mildly decreased distally with preserved motor strength, and no signs of acute infection or tissue loss were noted. All the other systems with positive signs and symptoms, again, explained in the injective. And her general her general mood was normal, and as well as her affect. She was in moderate distress, and she was alert and awake. So her diagnosis were right subclavian artery occlusion and pain in the right upper extremity. So the procedures performed were right carotid to subclavian bypass with a 4x7 mm graft, a right subclavian endarterectomy, and an arteriogram of the right subclavian. And so here we have pictures of the entry. So as we can see, we have complete occlusion to her subclavian, and we see it noted by the stenosis. Again, here we just have progressions of the arteriogram showing. And then again, we have it going down. We could see the mammary artery, right, Dr. Oye? And then this one, where is it? Here we have a preoperative versus the postoperative exam. As we can see, the big difference, we had complete occlusion, which really did show why she was having so much pain versus the postoperative image. So in conclusion, the radial pulses were present in the right post-surgery and no further complications were noted. However, post-op day 3, on post-op day 3, the patient presented with pain in the right upper extremity. A CT angiogram demonstrated occlusion of her bypass and was taken back to the OR for revision of the graft. The patient did well at the time of surgery. However, several days later on ultrasound, a CT of the chest showed possibility of a hematoma or an abscess collection on the infraclavicular area on the right, with some increased area of redness and pain. The patient was treated with IV Rocephin and vancomycin, but was later changed to IV Zyvox due to a vancomycin reaction. Pain management was done with hydrocodone and morphine, and a wound vac was placed during her hospital stay. But however, during the time of discharge, the patient was cleared without the need of a wound vac, and clinically, she is doing well. Now, case number 2, peripheral artery disease and a peripheral arterial disease recurrence in an elderly female. So a 90-year-old Caucasian female with a past medical history of peripheral artery disease presented with worsening right leg pain and discoloration. The pain has progressively increased and is associated with increased distal perfusion. On examination, distal pulses in the right lower extremity were absent. CTA of the abdomen with runoff demonstrated a short segment high-grade stenosis of the proximal right superficial femoral artery, complete occlusion of the mid-right superficial femoral artery, and vascular surgery was consulted. Her past medical history, again, she did have peripheral artery disease in the past, and this is a continued recurrence for this patient. Again, she is 90 years old and extremely active and independent. She does have diabetes mellitus, degenerative disc disease, and diverticulosis, past surgical history, cholecystectomy, hysterectomy. Family history was non-contributory, and social history, she did not smoke, drink, or use illicit drugs. Allergies unknown. So again, a brief summary of her physical exam. Vital signs were stable. Cardiovascular exam revealed diminished peripheral perfusion of the right lower extremity. The right foot demonstrated a discoloration in skin changes, shiny hairless. Distal pulses were absent on the right and diminished on the left. The right lower extremity was cold to touch with delayed capillary refill. Sensation was mildly decreased distally with preserved motor function, and this lady had no signs of acute infection or systemic illnesses were noted. So her diagnosis is where peripheral artery disease, thrombotic through sclerotic disease of the right superficial femoral artery, popliteal artery, and tibial arteries. Procedures performed were the right femoral popliteal bypass, below knee retrograde right popliteal SFA cannulation, antegrade embolectomy of the right anterior tibial artery at the tibioperoneal trunk with a Fogarty catheter, arteriogram of the right anterior tibial artery, tibioperoneal trunk runoff, repaired right anterior tibial artery at the tibioperoneal trunk origin, and endarterectomy of the popliteal artery. So here we have our images with the arteriogram. We're showing that there is clearly a lot of collaterals that were developed with this lady. I think that's why she was able to go for so long, and also helped the fact that she has how active she was in the process. But we're still seeing very little perfusion of the arteries. And here we just see just one artery. This is the image to the left is the medial, and then the one to the right is the lateral image. So as you can see, there's absolutely no blood flow, which is why we weren't able to locate any pulses on her. So here we're showing there's a stenosis on the image to the left. I don't know if you guys can see my mouse. There's a stenosis here to the image on the left. So here we're just trying to highlight, we're trying to get the balloon through the glide wire. And then here we have the balloon actually going through, and that's where we're going to try to expand the vessel. Here we see the dilation and that we're able to get some blood flowing. And here we have that we were able to open that stenosed area in the previous image, and we were able to allow for more blood circulation going through. So here we have images of the specimen collected. There was quite a few. There was quite a few specimens. We have the sclerotic plaque and a few blood clots as well. Here's image preoperative versus postoperative. As you can see in her right leg, the different color compared to the left. And post-operative, we can see that we could already see her color returning to the leg. Still a little bit red, but we're seeing a difference already. So this patient returned, unfortunately, this patient returned 2 months later with right leg pain and a right foot ulcer and absent distal pulses. CTA with runoff demonstrated a newly occluded right femoral popliteal bypass graft with stable occlusion of the right distal and left popliteal arteries. The patient recovered well post-operatively. Her favorable recovery likely reflects her active lifestyle and ability to develop collateral circulation despite its insufficiency. However, outcomes may differ significantly in settings with limited access to healthcare, highlighting the impact of socioeconomic and environmental factors. Given her advanced age and comorbid diabetes mellitus, the patient remains at increased risk for peripheral artery disease and related complications. Additionally, the loss of estrogen in postmenopausal women contributes to increased cardiovascular risk through adverse lipid changes and increased vascular inflammation, with epidemiologic data demonstrating a marked rise in cardiovascular disease incidence after menopause. So, with an aging global population and the rising prevalence of diabetes, peripheral artery disease is expected to become increasingly common. Proactive screening using the ankle brachial index is recommended for high-risk individuals, particularly smokers and patients with diabetes. To address the growing global burden of peripheral artery disease, priority should be given to expanding health services capacity, improving access to cost-effective treatment, and maximizing adherence to evidence-based management strategies. Continued dissemination of emerging strategies and novel treatment methodologies has the potential to reduce peripheral artery disease prevalence for future generations, including having conferences and foundations such as the ones that are present today. By increasing awareness and shedding light on the complexities of peripheral artery disease, individuals can be empowered to take a more proactive, preventive, and hands-on approach to their health. Here are my references. And thank you to Dr. Oye, the Oye Global Medical Foundation, Edward B. Dietrich Vascular Medical Society, Uzima Foundation, Bielsa Specialist Hospital, and the Vascular Clinic in Lagos. Thank you very much.
Thank you. A question, maybe question for you.
No question for you. Good. For your first case, the right carotid subclavian bypass, did you perform any or attempt to perform any endovascular interventions before proceeding to the bypass?
Yes.
Yes. So unfortunately, I wasn't with this patient. I didn't follow her as well, but knowing Dr. Oye, he is very keen on advocating for the patient and doing everything he can before having surgical intervention.
Yeah, she did have like an endovascular attempt, and it was not feasible. We went from subclavian a brachial approach as well as the femoral approach, and there was persistent dissection, which did not make it feasible to enter the true lumen to offer angioplasty stent and stenting in the normal situations. Or the patients who were able to have a wire go through lesion would definitely offer endovascular option as the first choice. She had a couple of attempts at endovascular option without success. And the second question for you, doctor, would be with the global health background and with the severity of peripheral arterial disease globally, how would you come up with a strategy to improve PAD?
So in my public health background, the main thing that I always advocate for is patient awareness and patient acknowledgement. And the patient has more control than they understand. And when bringing awareness, letting them know the different factors, the variables, their environment, their health, their diet, how much that actually contributes to their outcome in developing peripheral artery disease, I'm always going to say that's going to be the first place to go. Obviously, we have other factors such as the government and their role and what they play, what they allow in the grocery stores, what they allow, how they provide resources to allow people to become more active, the education that they put out into society. So all of those things, I believe, would help. It's a small stepping stone, but I feel like it would make a bigger difference than most people would realize.
Now, that's correct. Now, how would you improve the difficulties in medically challenged communities that, like you mentioned in your talk, are markedly more affected by peripheral artery disease issues? How would you tackle that problem where the resources are not as buoyant as in the United States or other developed countries? How would you take care of that problem?
So that's actually a difficult question to ask, especially in regions in Africa. So I know my family is from Cameroon, and I know that what they have access to is not the same as the things that I have access to, including information and resources. So unfortunately, I know a big role, government plays a big role. And there are times where they don't have a say in how they want things to go. So I know that's where it goes into elected officials and, just pressuring the government to just make these changes because we are our biggest obstacle. So in regions such as that, so like we have polluted water. Because if you think about it, the diet in the Western world versus in countries such as Africa, Cameroon, I'll speak for Cameroon because that's where I'm from, the diet is completely different. And I don't see, but you still see the prevalence of peripheral artery disease just as high, if not higher, in regions of Africa. And then also, as I was mentioning, the DALIs, it's more significant because of the lack of resources. Then they don't have those preventative measures, so they're going to go more into the amputations, or we're going to have the sickness, and the activities of daily life are also going to decrease. So I think that the government plays a strong role, and it's unfortunate that I have to say this, but I feel like that's the main people who you'll be able to see really implement and make a change to help the people in their countries.
Thank you. Yeah, let me ask a couple of questions that you got. A couple of questions for our first and second speakers. First speaker, Dr. Aycock, you're taking care of the patient who was elderly, correct?
Yes, sir.
94 years old, correct?
Yes, sir.
And the patient had revascularization, like you ably mentioned in your talk. And as part of the process, they were able to restore flow and do well. The question is, how can you, in clinical practice, engage non-surgeons, meaning the primary care physicians, to be aware that just because one is 90 or 94 does not mean that they need to lose the limb? How would you sell that awareness to primary care physicians?
To be aware of physical and mental acuity and activity more than age being a number. There are many people that would be younger than that would be less active. But when you see someone that's older, that should not preclude them for treatment that's activity-based if they're functioning at a high level. If we can maintain their high function, that should be the goal. And a primary care physician would have to say, yes, I have a cold foot on an older patient with diminished pulses, and not assume that it's part of a terminal disease process just because of the age of 94. And to make sure that there's a quick consult with a vascular specialist that can diagnose and make sure that that patient receives the care that they deserve for the activity level that they can still have.
Okay, very well. Now, how do you handle the situation, Dr. Aycock, on patients who who are misdiagnosed from their PAD? As we all know, PAD can be mimicked by other medical conditions, including arthritis and sciatica type problems. So, how would you uh, handle the patient who's misdiagnosed, and what options would you present to providers for them to ensure that they're actually doing the right thing by the patient?
The main thing for the providers would be education, because a primary care physician can tend, the old saying, when you hear hoof prints, you look for horses, not for zebras. The zebras are still there, and they need to be going down that path and making sure they consider it. And for peripheral artery disease, as was made clear to me today by another physician, touch the patient. Make sure that you understand what's going on there, and that you're not just assuming it, like may have happened in this case. They're 94, so their leg hurts, it's probably arthritis. Or they're 94, their leg hurts, they've probably been sitting around a lot. You need to be able to touch them and examine them and make sure that you understand and that you have the relationship with the vascular specialist or CV specialist that is going to respond to you when you say, I have a patient, they need help, can you please see them? So they don't get put at the back of the waiting list, so that nothing's assumed.
One of the for the audience, though, one of the problems we have in managing peripheral arterial disease is the fact that patients come in with peripheral arterial disease as one of our, as the young doctors have all mentioned. Their usual signs and symptoms. Dr. Ru did mention that signs and symptoms of peripheral arterial disease. The 5 or 6 P's. I should mention pain, palpability, pulselessness, paresthesia. It's important to know that for patients who have who present with pain in the leg, one must not just assume they have arthritis or sciatica. You have to examine the arteries, the pulses. If they don't have a pulse, then one would worry that they may have a PAD-related issue. Now, just examine a pulse with your fingers is not good enough. It's important to use the Doppler, handheld Doppler, to actually listen for the pulse and ensure there's the pulse. Because if you're using your finger and the person who is pulseless, there's a great possibility you might be feeling your own pulse, and you may erroneously tell the patient that they have a pulse, and therefore you make that critical mistake or telling the patients that, oh, they're okay, and they believe you as a physician or a doctor that they're okay, and they go home and not show up again. And if it's a non-compliant patient, the next time they show up, it will be with the situation of advanced disease, where that relative ischemia in the beginning now has become an absolute ischemia, and they would definitely lose their limb at that point. Again, this is a medical legal issue. Even in the USA, as advanced as we are, physicians still make that critical error of missing a correct diagnosis of peripheral arterial disease of PAD, as reflected in the 94-year-old patient that Dr. Aycock has presented. Yes, she's 94. Yes, presented to a primary care physician. Yes, she was told she had arthritis. And yes, she was given a shot of steroids, and she was sent home. If she did not have an astute family unit or members who were not satisfied with her progress and brought her back to the emergency department to be reevaluated, she probably would have lost a leg. Again, she was 94. She did well, and that's a concern.
And just to add, and she had also been off of warfarin for 5 days.
Yes, correct. Again, she was off anticoagulation for 5 days. That's another reason why you'd would want to ensure that she did not have a clot issues. We have a question from the audience, Dr. Shangade.
Yeah, a very nice talk for the last speaker. I enjoyed that very much. I mean, I think you've all emphasize the importance of do not discriminate on account of age. This lady you presented was very active, so that's enough reason to go ahead and intervene as best as possible. The other issues, I see a lot of patients in my practice that are diagnosed, the commonest diagnosis is neuropathy. Everybody got neuropathy. And then when I lay my hand on their foot and I don't feel any pulse, or I tell the nurse to give me the Doppler stuff, and then I'll say, well, see, it's not just neuropathy. So there's a lot of misdiagnosis, just like Dr. Oye said. So those are the two things the audience should take along. Not everybody is neuropathy or degenerative joint disease of the spine. Rule out vascular insufficiency. Do not discriminate about age. Now, so that's just my short comment. But the question to Dr. Oye and to the young lady that presented, those two patients, what kind of anticoagulation did you send them home after you discharged them or when they were in the hospital? Thank you.
And usually in my clinical practice, I usually send our patients home if they don't have allergies to clopidogrel, generic Plavix, 75 milligrams once a day, and aspirin 81 milligrams. That's my baseline. However, for patients who come in with a significant thrombotic event, nowadays we can give them low dose Xarelto, low dose Eliquis, in addition to the Plavix and aspirin, if they don't have any risk factors for significant bleeding. In the case I referred, we did Plavix and aspirin.
How long do they have to do that the rest of their life, or do you have an algorithm as to when they can stop? Because patients always ask me that, and I don't have a typical answer.
Yeah, for our typical vascular patients, because our subset of patients are really sick and they do have advanced ischemia. So I typically put them on Plavix and aspirin for life if they can afford it. If they come in with significant thromboses, then the Eliquis is added, or or at least for about 3 months. But ultimately, I can drop the Eliquis and leave them Plavix and aspirin much longer. If the financial concern is of great importance to the patient, at minimum, I'll double the dose of aspirin and take them off Plavix. Down the road, if they're doing really well. But they have to be on some form of anticoagulation at minimum aspirin for life.
Thank you.
Yeah, okay, very well. Again, Dr. Shangri, thank you for the question. It's also important to mention that neuropathy, as clinicians, primary care physicians will indicate patients have neuropathy. Again, as young doctors seeing patients, if a patient shows up to your clinic and you evaluate the patient, the most important thing you have to ask the patient is the onset of their problem and what the problem is. So history is very important in identifying what they may have. 90% of the time, patients will tell you what the problem is, even without doing a test. So as physicians and training physicians out of training, our goal is to figure out if what the patients are telling us is indeed correct, and then use confirmatory physical examination first before going in to do complicated examinations. Okay, the art and science of medicine surgery has been lost, where we jump straight to testing without examining patients, and that has been seen and can lead to major medical legal consequences. I'll give you a case in point. A patient comes in with an abdominal aortic aneurysm, say a 67-year-old gentleman who was having pain for 2 weeks, was around the holidays, Thanksgiving, never showed up to the hospital. Then he goes to hospital A, emergency room. Because the wait time was long, he signed out and left. He goes to hospital B, emergency room, and in hospital B, he was seen, checked at 11 a.m. in the morning, was seen at 1 a.m. in the afternoon, at 1 p.m. in the afternoon. And the emergency room department physician probably did not fully examine the patient, because if he did, he would have known that the patient had a problem. But on the notes of emergency physician, our diagnosis was possible appendicitis, cholecystitis, diverticulitis in the patient who had an obvious abdominal aortic aneurysm that was bounding. So because the physician did not lay his hands on the patient, he missed an obvious diagnosis of abdominal aortic aneurysm in the belly. As a result, the test now the doctor ordered was inappropriate. Instead of ordering a plain CT of the abdomen with contrast, IV contrast, if or CT angiogram would run off if they knew it was abdominal aneurysm on the initial assessment, they ordered CT of the abdomen with oral and IV contrast. When you do oral IV contrast, then you give contrast to the patient, you have to drink contrast, you have to wait much longer, so much time gets wasted. On the other hand, for the person who has abdominal aneurysm, you can either do a CT of the abdomen with contrast, or CT angiogram would run off, or you can do a plain ultrasound immediately, and it'll tell you they have an abdominal aneurysm if you have any concerns, because your treatment algorithm gets faster once you've done that, and you're able now to get your appropriate consultation vascular-wise and to manage the patient. It was unfortunate for this patient because the misdiagnosis, because of the chronicity of his symptoms, 2 weeks. By the time a vascular consultation was now obtained by 6 p.m. that same evening, the patient had this CT of the abdomen with oral IV contrast, obvious aneurysm concern at that point, evaluated, and then noticed that on examination that patient had pulses. However, patient had bad cardiac status, pulmonary status was bad, and ultimately patient ruptured and died. Again, if this patient had been given a CT angiogram of abdomen, even ultrasound early on in the course, that diagnosis of abdominal aneurysm would have been made early on, and the patient would have been treated much sooner, offered treatment much sooner, versus waiting until the latter time of the day when the patient ultimately ruptured and unfortunately died. So again, it's important to examine the patient. That's a take-home message. Okay, so I'm going to move on to our next speaker. Our next speaker will be soon Dr. Michael Aycock.
More difficult.
He did the first presentation of the session, and is going to grace us again with another talk.
Thank you, Dr. Oye. We had a patient come in that was more difficult than expected. We had a groin incision clearance of a known blockages of the femoral, profunda, and popliteal arteries. And when that was over, we thought we were going to see a well-perfused lower leg, and then followed by unexpected blockages of the distal extremity. That's what will be emphasized in this particular presentation. Our patient is a 74-year-old male. He's got a history of AFib, hypertension, peripheral artery disease, and transient ischemic attacks. Those were about 10 years back. He's active and high functioning and has full mobility. I apologize. Some of my highlighting is not coming out in the computer switch. I'll try to do it here with the pointer. We knew that there were blockages in this area. Okay? We knew there were blockages in this area. We did not know that there were blockages in this area. So, and that's what these down here were supposed to indicate. So it was sort of a surprise. What was expected to happen, upper leg clearance. An incision was made. Previous imaging and fluoroscopy confirmed the occlusions of the femoral, profunda, and popliteals. Plaques and clots were cleared with traditional methods and shockwave. As discussed in the other presentation, and the flow to below the knee was evident, and we believe the surgery was near complete. What was not expected, when the upper procedure was complete, the foot was still cold and pulseless. We did not get anything on the Doppler. Contrast fluoroscopy then revealed complete blockages of the posterior tibial and anterior tibial arteries. This was not evident prior to surgery because of the blockages upstream in the femoral and profunda arteries, more central to the arterial flow. And CT angiogram is not as effective for tibial perineal arterial visualization. Contrast fluoroscopy, once blood supply was present, was a more definitive indication. Incision was made, revealing the posterior tibial artery near the ankle. Issues were from that incision, medial foot, we were able to move up and clear the posterior tibial artery. Then the difficult part came in, and a smaller wire was run distally through the arteries of the foot and then moved retrograde up the tibial artery. This allowed clearance with traditional methods. These blood vessels on average are 1.5 to 3 millimeters in diameter in the plantar arteries. This led to pulses in the foot and almost immediate signs of blood flow throughout the foot. This next image showing the change is dramatic, and it happened in about 1 minute. So on the left, you can see the clearly ischemic foot, and about a minute later, that was its appearance on the right. And it was, I'm a student, and that was pretty dramatic to see. 2 days post-op, the patient is resting comfortably. Pain medication is being reduced as he becomes more comfortable. The foot is maintaining pulses, is warm, and has minimal swelling. Some of the discoloration from the long-term ischemia is beginning to fade, and he has a good prognosis. Now, it became more complicated, so these are notes that were added to the slide. The patient has a warm, this was later that week. A patient has a warm pink foot with pulses. However, the toes and possibly distal foot are clear to touch, are cool to the touch, and maybe ischemic. There's some increased discoloration. Another CT angiogram was ordered. An additional procedure may have been required. Here's where you can see the occluded arteries, meaning that there was no blood down into the foot. And I don't know why it did that with my letter Y. The wire placement was key to success. The physician was able to enter the posterior tibial, come down the lateral plantar, move through the deep plantar up to the dorsal pedis and to the anterior tibial. That eliminated the need for a second incision point, and this allowed for retrograde balloon angioplasty. And here you can see some of the angioplasty being performed through the foot into the tibial, dorsal pedis, and anterior tibial arteries. Here you can see the incision site. Over here you can see the patching that was performed. I think there was an illustration of the patching on one of our other student physicians' illustrations. And here you can see some of the clots that were removed. The prognosis is good. The patient did require another angioplasty of the anterior tibial artery from the groin. It is possible there may be some loss of tissue in the toes and distal foot. This will be determined in the coming weeks. Without the surgery, in a timely manner, the patient would have faced amputation, loss of use, mobility, infection, sepsis, and diminished quality of life. And that's my presentation, and I appreciate it. Thank you.
Thank you. Thank you very much, Doug. Again, that's a very interesting presentation for patients who shows up with an ischemic leg. And time is of the essence when you have a patient presenting with an ischemic leg. The downside for this patient is presented about 9 days after the fact. Again, there's a concept of absolute ischemia and relative ischemia. That's like an 8-hour window where you may start to have irreversible changes to the lower extremities. On clinical examination, it's important that we ask the patients to wiggle their toes. If the patient's still able to wiggle their toes, this fellow was 9 days out, but he was still able to wiggle his toes, which gave us a little more confidence that whatever we did might work. If, on the other hand, he is not able to wiggle his toes, or he has a slightly dead foot, then your question is, what do you do next? When you have a patient that has multi-segmental problems, like in this case, the profunda or deep femoral artery keeps the leg alive, and the SFA, the superficial artery, can make you walk. This patient has had the profunda artery was was out. He had blood clot profundus, so we had to do an embolectomy to remove the clot from that. That helped the collateralization towards lower extremities and at the conclusion of surgery. But because of the distal issues he had, if you don't do as much to restore flow to the digital vessels, then the chances of limb salvage will be less. When we talk about limb salvage and you look at foot, you have to, number one, ask yourself the following question: is the foot viable or salvageable? If I do surgery, will the specimen be able to return back to the usual mode of life? If the foot is just completely dead, has gangrene, is foul smelling, and there's no chance that whatever you do would work, then those are the class of patients that would require definitive amputations. Where we don't subscribe to amputation as our first goal, but we subscribe to amputation for those patients who at presentation have a totally irreversible ischemia or dead foot. The reason why you do that is to prevent them from having severe rhabdomyolysis, where the breakdown of muscle will eventually dump its contents of kidneys, and they will get kidney shutdown and ultimately other multi-system organ failure and eventual death, sepsis included. So in this case, he was lucky we were able to restore flow. And that's the value again of first patient awareness. The reason why we're doing this conference is patient awareness. Patients must know about PAD and its ramifications, not only for the patients, the families also have to know that, because sometimes what's the first thing most patients do when they have a problem? They deny they have a problem. A patient having chest pain will deny they're having chest pain, until they have a major heart attack. So again, it's the same concept with the lower extremities. I have pain. I think it's going to go away. Let me wait another 24 hours. And time is of the essence for this patient. So it's important, again, that we raise awareness, not for the patient alone, not for the patient's family alone, but also for the primary care providers, because the primary care providers are the gatekeepers for these patients. If the primary care providers are not skilled enough to identify that patients have a problem, the patients will lose their limb. Again, when I go across the pond to see patients, I'm amazed at the fact that PAD is missed, number one, and number two, if the index of suspicion is not there, then it becomes another problem. Again, and across the pond, a lot of people talk about malaria, typhoid, and all those issues, and somebody may be having an ischemic bowel issue. So again, it's important to have increased awareness that the patient may have a PAD-related reason for their symptomology. So that's a great talk. Well, next present. Any questions from the audience at this time?
Oh, question, just out of curiosity. Like when you went retrograde from the posterior tibia of the ankle, what techniques did you employ to restore flow?
I think he used angioplasty almost entirely at that point. He didn't stent, and I don't remember using shockwave in that area.
We did angioplasty because there was a blood clot disease. Shockwave is not advised, and when you have blood clot issues, except there's significant atherosclerosis combined with that, where you've already cleared the blood clot.
Hello.
So,
Good morning.
Good morning.
Yeah, this is the Lou.
Hello.
I'm doing well.
Hello. Any question there? Okay, I guess that's all. All right, so let's go ahead to our next presenter. Dr. Ru, the floor is yours.
Yes, this. Hi, so I will be covering another case that we did. This one is endovascular management of central venous occlusion in a hemodialysis patient with malfunctioning arteriovenous graft. So to begin a little bit about end-stage renal disease, which this patient had. So end-stage renal disease is kind of the final stage of chronic kidney disease, where the kidneys are no longer functioning and they're not able to sustain life. And what happens in these patients is that they're going to require either long-term hemodialysis or a kidney transplant in order to live. There's no cure for kidney failure, so they need to get one of these things. Some of the symptoms include fatigue, swelling, and nausea. And some of the common causes we see are diabetes and high blood pressure. Other risk factors also include heart disease and a family history of kidney failure. So here are some of the top symptoms you see in these patients. They start out with fatigue and weakness. They can have some swelling in the arms or the legs. They can have nausea, vomiting, loss of appetite, muscle cramps, shortness of breath, and also they will have decreased urination. Now, the statistics in USA is that chronic kidney disease affects more than 1 in 7 US adults, and that's an estimated 35.5 million Americans. And about 1 in 3 people with diabetes and 1 in 5 people with high blood pressure also have kidney disease. Now, with time, kidney disease often gets worse. It can lead to a kidney failure. It can lead to other health problems, stroke, or a heart attack. And additionally, approximately 2 in 1,000 Americans are living with end-stage kidney disease. So as I mentioned, there's 2 options. You can go ahead and do dialysis, or you can get a kidney transplant. A kidney transplant requires time and you have to have a proper match. So oftentimes these patients will start out with hemodialysis while they are placed on a wait list for a kidney transplant. With dialysis, what they do is they're going to have an artificial filter where they will filter the blood the same way the kidneys would. And it's a life-sustaining treatment, but it's not a cure. There are different types of hemodialysis methods. So, for example, you can have the in-center hemodialysis. The patient will just go to the hospital about 3 to 4 times a week. They sit there and a machine will clean out the blood. It'll send it through a mesh filter and it will filter out the blood and return the blood to the patient. There's also at-home dialysis for patients who may not be able to come to the hospital. And in this case, again, they're just at home, similar procedure, similar machine. There'll be a dialysate fluid going into the patient. It'll filter out the blood and then return the blood to the patient. And there's also nocturnal automated peritoneal hemodialysis. This method uses the peritoneal lining to filter out the blood, and the dialysate fluid is put in the patient while they're sleeping. And this can be helpful for patients who are very busy during the day and don't have time to be dialyzing during the day. With our patient, he was a 58-year-old male. He was a hemodialysis individual and he had end-stage renal disease and he had a malfunctioning left upper extremity arteriovenous graft. So with hemodialysis patients, they can have kind of an access site. And if their vein and artery are very short or for whatever reason, you'd put in a graft, which is just like a hollow tube. And you can see that in this image up top. It's just a hollow tube that connects between the artery and the vein, and it'll allow as an access site for the hemodialysis. Unfortunately, the problem with grafts is that they can have like stenosis, they can have narrowing because of the tissue hyperplasia, and that's kind of what happened in this patient. So he came in, he had significant swelling of the left upper extremity, and that was consistent with the venous outflow obstruction of the left subclavian vein at the axillary junction. And you can see that in this picture where he has an obstruction here. If this patient had had, for example, a fistula, which is the natural connection between an artery and vein, it would have been less likely to stenose and have this problem. So in this patient, he had end-stage renal disease. He had a malfunctioning AV graft in the left arm. The left subclavian vein occlusion led to lymphedema. And you can see in this picture, his left arm is very swollen compared to his right. That's what we're trying to illustrate in this image. The procedure that we did for this patient was we started with informed consent. A timeout was then performed, and the AV graft was cannulated using a microvenous needle. We used venography to confirm the occlusion in the proximal left subclavian. And after that, we used various French sheets for sequential advancement. A glide wire was used to navigate the occluded segment with assistance from a NaviCross catheter, and that was followed then by an Advantage guide wire. You can see one down here. Afterwards, we did angioplasty with a balloon, and there was some persistent residual stenosis. So then we had to use a covered stent in the left subclavian vein. So in this image, you can see the balloon that was used. This is what it looks like when it's not inside the patient. Yeah.
Go back one.
Sorry.
That showed that there was a tight area between the balloon when the balloon was inflated. High-grade stenosis right there.
And then we had angioplasty with a non-compliant balloon with additional angioplasty for the adjacent stenotic components. And then we had stent apposition, which was achieved with the resolution of the stenosis. There was improved flow through the AV graft. You can see the stent here. So once that was all done, we were able to there was an AV graft thrill, which we were able to see, which was restored following the intervention. And this patient was very lucky. There were no intraoperative complications. And I'm going to show a before and after picture in a moment. This was the after picture, but I'll show a comparison in a moment. So the post-op estimated blood loss was about 100 milliliters. We didn't obtain any specimens during this procedure. The access site was closed with Prolene sutures and benzoin steri-strips, 4x4 gauze, Curlix, and ACE wraps were applied. And this patient tolerated the procedure very well, and of course, they experienced improved AV graft function. So in the before picture, as you can see here, there is a left subclavian vein occlusion at the axillary junction. And in the after picture, we had restored the blood flow, and we could, there was an AV thrill that we could hear. So central venous occlusion and stenosis are documented complications in patients who are receiving hemodialysis. And usually it's related to like prior central venous catheter use and also altered venous hemodynamics. And the problem is these lesions then lead to venous hypertension. They can lead to lymphedema, failure of the arteriovenous access. What we do is we go ahead and use endovascular therapy, which has now emerged as a really great first-line treatment. It's minimally invasive and it has a really favorable safety profile. The strengths of this procedure was that, of course, it salvaged the existing graft and it avoided the need for like a temporary dialysis catheter, didn't need a new access creation like in the other limb. It was also minimally invasive because we performed endovascularly without any kind of open surgery. There's a low morbidity when we compare it to a surgical bypass. And there's short recovery time with these procedures. It was well tolerated in this patient. We avoided more complex surgical options, such as like central venous bypass. We avoided access ligation. There was reduced anesthesia and the operative risk, and it's really beneficial in end-stage renal disease patients. Highly technical success despite the complete occlusion. So what we see in this patient was we successfully crossed 100% occluded central vein. And it demonstrates feasibility even in advanced disease. Some of the limitations with this procedure is that there is a risk of restenosis, and you have to often repeat this intervention, and long-term patency is not guaranteed. The other issue is that it does not address the underlying disease process. So, of course, we did not reverse the endothelial injury or any of the dialysis-related venous scarring, and progression of the venous disease is common. The stent-related risk is, as I mentioned before, the restenosis can happen. You can have stent thrombosis. It also somewhat limits the future surgical options in the stented segment because it's kind of like a last resort. And then you definitely need to survey these patients lifelong, continue to monitor them, make sure that they're doing well, and you might need to actually go in and have a repeat angioplasty or restenting. So over time, you could say it's resource intensive. Overall, endovascular angioplasty with the covered stent placement offered a really effective and minimally invasive method for this patient who had a central venous occlusion. And early intervention may actually preserve vascular access and improve patient outcomes. But the long-term durability is kind of limited by the high restenosis rates and, of course, the ongoing need for surveillance and repeat intervention. And as always, I have acknowledgements here to Dr. Oye, the surgical team at Raleigh General, and the anesthesia team at Raleigh. Thank you.
Thank you. Nice talk. Very well. Nicely done. Any questions from the audience?
Oh, quick question, Lee. Patients with end-stage renal disease, as most of us know, they're unable to tolerate high amounts of contrast. How is that accounted for when you were doing the endovascular procedure and you had to inject contrast to perform venography and angiography?
They already are end-stage renal disease and already receiving dialysis already. So that would not be a major issue unless if they were not on dialysis ahead of time and they were trending towards dialysis and you are concerned that the contrast load might tilt them to becoming dialysis, to receiving dialysis. So patients that have end-stage renal disease are typically, they're already on dialysis and we know they're not going to reverse. We just give them whatever contrast we're going to give them. And after surgery, they typically get the next scheduled dialysis, either the same day or the next day. Yeah. With respect to this talk, Dr. Rue, things that we need to remember. Number one, the best choice for patient who's on dialysis, since they're hemodialysis or peritoneal dialysis, but if they're on dialysis, they're hemodialysis. The better choice for treatment is AV fistula is a preferred route, if possible. AV graft as a second option. In our experience in the US, we're able to use AV graft, AV fistulas fairly well. Our technologists and nurses are able to kind the grafts just as well. In other parts of the world, the grafts are not common. The fistulas are the more useful way for dialysis, so they're not very confident using candidate grafts. So it becomes a problem. So if you're doing an AV access in Africa, you want to pretty much use a fistula if possible, because the techs are more prone to using fistulas more versus grafts, because they have real problems doing that. Again, who gets the neointimyoplasia and why? If you have AV graft formed, the neointimyoplasia and the neointimyoplasia is more common in the AV graft segment because of the graft material. And it's more towards the venous end of the anastomosis because it has lower flow in that area from turbulence. So the neointimyoplasia forms more on the venous end of the graft. But it doesn't matter if they are having a central venous occlusion like you demonstrated in your talk. It doesn't matter if this AV fistula or AV graft they have. If they have a central venous occlusion, that is most likely due to, like you mentioned, a catheter manipulation in the past, a permanent catheter central line, especially with subclavian vein used rather than IJ. We prefer the IJ route if you're going to put a central line, but if you're going to put a central line, you want to make sure it's IJ and less likely subclavian, because they would repeated cannulation, renal patients that have a repeated cannulation of the subclavian veins, catheter placed in there, will develop the stenosis. Now, then they have an AV fistula created. Then at some point, if the fistula is working well, then they have the disease, the stenosis, no occlusion of the central portion. In this particular patient, he did have still functioning AV fistula thrill, AV graft thrill. The thrill was still present, but the occlusion was still there. And whenever we see these patients, we clinically look at them and say, well, examine them, like I mentioned before, examine your patients. Patients that have central venous stenosis will have collateralization of the veins on the skin that you could actually see. That will tell you that they have a central stenosis. And it's now based on your clinical judgment to now confirm it by doing the venogram, by sticking the fistula graft, shooting the contrast, and you're able to immediately find out this stenotic, stenotic or occluded, and then you effective treatment option. If it's a minor stenosis where a balloon angioplasty opens it up fully well, where you don't think you need to put a stent, then you don't. But if, as in this case, where you have complete occlusion, if you don't put a stent, it will recoil and the patient will be back. So we typically put stents, and we prefer to use covered stents when possible for these patients at that region. Again, one of the things to also see for patients with renal failure in the US, we have an algorithm that come with renal failure. They're seen may get initial catheter, it's acute event. Ultimately, we try to get them on the fistula list, get a fistula done, and 2.5, 3 months later, we try to take the catheter out to minimize the risk of subclavian venous occlusion in the future. And then they go through the placement for potential dialysis, potential kidney renal transplant. In other parts of the world, the mindset's totally different. It's 100% different. Where somebody has acute renal failure in Africa, for example, the first thing they will do is, I want a kidney transplant. And the next thing, in Nigeria particularly, they want to go to India, or they want to go to Dubai or go someplace else, get a transplant, or Turkey. And they don't want to go through the headaches of going through a fistula, And what happens, they go have the kidney transplant, sometimes suboptimally well-matched, suboptimally matched kidneys. And then they get anti-rejection drugs for X amount of time, maybe 2-3 months at the host country. Then they come back to their homeland. Then they develop form pulmonary edema, acute renal failure, and they die. So we need an awareness campaign to tell our primary care physicians in those countries in Africa that to kind of change the mindset that they need to go through the fistula before renal transplant and get adequately well worked up for kidney transplantation. Now we're doing a lot of kidney transplantation in Africa too, so they don't have to travel out as much. It's also important for these patients to understand that it's a process, that kidneys are not just grown someplace else. You need somebody to donate a kidney, if it's not a family member, if you get them someplace else, so that the transplant list is very important. And also nowadays they have black market kidney transplant issues too, which is another problem in third world countries where people do black market kidneys, the way they lure young people and take their kidneys out. And so it's a big market out there too. So it's a problem. So it's education, but that's a great talk for patients who are on dialysis. Another major issues for dialysis patients, if you have a good dialysis nurse or center, they're able to identify that the fistula is having an issue early on. As the fistula starts to demonstrate high venous pressure, it's a clue that something's wrong. So if they now refer those patients early on to the endovascular interventionist, then they can do the venogram, figure out that it's a minor problem, balloon, rather than wait on the fistula or graft completely thrombosis or clots up. When the complete thrombosis clot up, then it's much bigger operation for the patient. If they're still partially working, it's much faster for the patient. Yeah. Okay. Very good. Any further questions from the audience? Yeah. Anybody else? Questions from the audience? All right. So, yeah. All right. Submission. Yeah. Question. Wait for sure. Yeah. Okay.
I get the right one.
Okay.
Wound healing.
Okay. Wound healing. Here's one more talk. Okay.
Thank you, sir.
Okay.
Hello, it's Michael Aycock again. I titled it "On the Way to Success" because we haven't seen the last steps with this patient. The last steps will be months away. This is a healing of diabetic ischemic leg ulcer over time with aggressive debridement, cleaning, and dressings. And the point is that with consistent care, that some of these issues can be resolved better than you think. If you look here at the very first slide, you can see the worst state that I saw on this leg. And on the lower slide, please remember that pink is good. Pink represents vascularization and it represents granulation material. I'm sorry for the noise in the background. Okay. The patient is 83-year-old female, diabetes, peripheral artery disease. 10 months prior, she had revascularization of the femoral and perineal arteries using traditional methods. Peripheral pulses present since this procedure. Hypertension, successful healing of ulcerated area over the Achilles. Scars indicating healed ulcers over the tibia just distal to the knee. I won't go over all of the techniques that were used, but it was an aggressive process of cleaning with the products that you see using a heat lamp and lymphedema compression. Miragen is a newer product. It's a silicone borate glass fiber matrix, and you put it in the granulating areas. And it helps with the granulation. It helps with the vascularization. It provides sort of a matrix, as the word says, for the granulation material to form over. Saline betadine, wound wash. The curette and scalpel debridement is very important. And then the types of dressings that we used. And beginning in October, the patient was coming in approximately once every 2 weeks. Progress was slow but steady. You could see the edges of the wound coming in. We believe that in the future there will be a skin graft involved, but we were trying to get to a solid wound base of granulation material before we got to that point. Then when the holidays came, we didn't see this patient for 6 weeks. In late December, after the holidays, infection and necrotic tissue were evident. Antibiotics and frequent office visits were begun. From December 29th until January 30th, there were 7 appointments of the physician cleaning and medicating and bandaging. Here's the progression. You can see, and again, it had a little bit of trouble going from one slide form to another, and I apologize. On the upper left is in early October, and you can see the first 4 appointments here, and here from the October to mid-November. Then this patient, this slide here that's so dramatic, that's at the end of December. Then we began oral antibiotics and treatment, and this one's under a bandage. I apologize. The rest are just the pictures were taken right when it was wiped and cleaned at the beginning before treatment occurred, and of course at the appointments the necrotic tissue is removed with the curette or just wiping it with a 4x4 at times, and you can see the improvement. This is the most recent. This was just this past week. And this is the image of the wound after the removal of the dressing and initial cleaning. And then this is after the curette treatment and other debridement and everything that occurred. And remember, pink is good. So the patient will return in 4 days. This is an excerpt from the most recent appointment summary, and you can read the whole thing. But what's most important in this summary to me, right leg wound with good granulation tissue over 80%. If you think of that compared to what we saw at the end of December, that's remarkable. Following treatments will continue to encourage formulation of granulation. Further, skin grafting is likely. Okay? Now, without care, this patient faced infection, sepsis, loss of additional tissue, loss of use, amputation, and possibly life-threatening conditions. That infection could not be allowed to stay, and you've got to keep the necrotic tissue away. Helpful references. The American Heart Association has a a very good document, and I just named it. You can find it in a bunch of locations, but I named it with the date so you could search it. And it explains why these things occur in diabetics and why it occurs with lack of arterial perfusion. And then if you move from a vascular primary care office to a wound care physician, they have other modalities: hyperbarics, seal dressings with low pressure pump, biometric debridement. And much of what a wound care physician does is treatment of peripheral artery disease, simply working on the exterior wounds. So they are part of the team. Now, if it can, and this patient was kept in this office because it was vascularly based and had already been a patient of ours. This patient is being treated, and the results have been positive. There's an interesting website, and it is free access to the continuing medical education programs given to wound care physicians. It's called the Wound Care Window, and you can watch the processes being done. And this is a flow chart to help you understand, and this is from the American Heart Association, understand how to treat these vascular ulcers. And it's clear about, it wasn't peripheral artery disease, or wasn't it? And it has you, then that goes back to what the doctor was saying, that you've got to examine, you've got to determine. So once you know what the source of everything is, it tells you which directions to go and how to treat. And if it's not peripheral artery disease, you've got to think about other things and not just say, well, there's a pulse and there's a pain. So then you've got to deal with rheumatology and dermatology and autoimmune and cancer and other things that could be possible. So if it's in the initial exam, please consider those things. And thank you. And I just completed my rotation with Dr. Oye. Thank you very much for your help, and thank you to the Raleigh General staff and everyone.
Thank you, Mike. Appreciate it. Yeah, very well. Nice talk. Any questions from the audience? Dr. Chafeh?
Yeah, I think he kind of touched base with everything. We see a lot of this wound at the wound center at Raleigh General Hospital, one of the top-notch wound center in the country. So what he said is appropriate, and aggressive treatment is important. We always involve the vascular surgeon in this case because we want to see the way the vascular supply to this wound is. So it's amazing. Once we see a non-healing ulcer, we send to the vascular surgeon, either Dr. Oye or Dr. White, and they revascularize. It's amazing how quickly the wound heals. So our emphasis is to prevent amputation and to heal the wound as quickly as possible. So we work in together with the vascular surgeon to get our wound healed, which is the main aim. Many years ago, wound care is regarded as very dirty and useless, and this kind of, many doctors do not want to get involved. The science of wound healing has really progressed, and there's so many modalities now that we use. Hyperbaric oxygen is one of it. There are definite indication for using HBO, so we don't just use it for everybody. So thank you very much, the young doctor. Thank you.
Thank you very much. Any further questions from the audience here? All right. Well, thank you again very much, and we appreciate you being able to join us today in this first quarter Global Ground Rounds for 2026. It's our pleasure again to say our goal in this mission is to disseminate information for clinicians and non-clinicians worldwide. Our goal is to ensure that patients understand it's important for them to seek help early in the course of the disease process. Theme for today centered on peripheral artery disease and central venous access improvement in renal patients. The speakers were my young doctors who have done a fantastic job today. And our goal also as part of this exercise is to have these young doctors become very adept at understanding vascular diseases. So when they go out in clinical practice, they will not make the fatal errors of missing the peripheral arterial disease related problem that can lead to amputation or lawsuits. Again, the collaborators for this program are the Oye Global Medical Foundation, Uzima foundation that would be the Vascular Surgical Society, Special Hospital, as well as the Endovascular Clinic Lagos. We like to say again, PAD is a global hazard. It's a global medical hazard because it ultimately leads to limb loss and death when not well taken care of. There are global disparities in the provision of healthcare. The global disparities are striking if you are not living in a first world country. And even if you live in a first world country, you can still miss PAD even by skilled physicians. That's why I encourage medical students to do a rotation vascular surgery because it will heighten their awareness for vascular disease processes in their clinical practices. The dichotomy in care and management PAD and vascular in general varies, depends on where you live. If you live in the United States of America, resources are there, insurance coverage is there. You can do a lot of stuff to make sure you don't lose a limb. If you live in other parts of the world that don't have those resources, your outcome may not be as good. We have today presented very advanced cases of PAD, even in elderly patients as old as 90 and 94, with excellent outcomes. The same cannot be said if these patients were in other parts of the world, especially third world countries that don't have the equal amount of resources to mitigate these problems. So we have to rely on the primary care providers in those communities to have a high index of suspicion that their patients are having issues, so they're treated early on in the course before they present as advanced diseases. Again, another issue we have in third world countries is the fact that because patients cannot afford care, they delay their care and or seek other means for care, which sometimes may not be in their best interest. There's no problem with praying, but having your pastor or imam pray for you and not seek medical care when you need care can be dangerous to your health. Yes, they can pray for you, but also you have to look for the person to manage your care so you don't lose your limb. The affordability of care is a big issue in those countries. Inadequate endovascular specialists or physicians who will intervene if a problem is identified continues to be a vexing problem in those parts of the world. Therefore, even in the United States, we do know that we don't have enough endovascular specialists, especially in rural America, who can manage some of these problems. If we don't have enough in the US alone, think about the other parts of the world that really don't have much. Again, we have to change our training algorithm to ensure that persons who have surgical training of some sort, maybe cardiac surgeons, general surgeons, can be retrained via mini fellowships in vascular disease processes management, so they can be added tool in our toolbox. We have the opportunity in the US to have a giant box, a toolbox, where we have all these important tools we use for treatment, the balloons, the wires, the stents, the atherectomy devices. Those are the things that are not common or available in third world countries. And I give homage to third world country physicians who, under hard or harsh circumstances, are still creative in using whatever they have to affect care. We need to encourage them. We need to strengthen our collaborations with these physicians and institutions so the PAD management can continue to improve, and we can therefore minimize limb loss and loss of lives. Again, once again, thank you so much for joining us today, and we look forward to seeing you on our next global ground rounds, which we in about 3 months from now. And we'd like to thank our participating young doctors for an excellent job in presentation, and we'd also like to thank the audience for joining us today in making this possible. Thank you so much, and have a good day. Right. Nice job, y'all.
Thank you, Doctor.